Assalamu alaikum. Hello everyone. I would like to welcome you all in the 19th annual Symposium of Shaukat Khanum, Day 3, Oncology Pharmacy session. My name is Zara Hashmi and I am delighted to be your host for this session. Now, the total duration of this session will be 1 hour 30 minutes. That will be covered by our four renowned speakers. We are privileged to have this session chaired by Dr. Mohammad Tahir Aziz, who is the Chief Operating Officer at Shaukat Khanum Peshawar, and co-chaired by Mr. Umar Iklag Bhutta, who is the Associate Director Pharmacy at Shaukat Khanum Lahore. Now, let me begin the session by saying that if you want to go somewhere, it is best to find somebody who has already been there. So, on that code, I would like to invite our first speaker, Mr. Khurram Shehzad, Senior Pharmacist at National Guard Hospital, Chetta. And he'll be speaking on the topic of era of modernization, stepping towards standardized oncology pharmaceutical services. Over to you, sir.
Thank you very much for your kind introduction. And I'm so pleased to be involved in this symposium. And I would like to congratulate the Shaukat Khanum team and the pharmacy team for arranging such a wonderful event, even this pandemic situation in Iraq. Is my voice is clear? Is it okay? My screen is okay? Because I can't able to see anybody or fine. So I have no financial relationship to disclose, and okay, thank you very much. I got the message that is clear, and I'm not endorsing any product or service mentioned during my presentation. Well, let me. Okay, the topic which I'm going to discuss with you is very advanced, very complex, and it's about the standardization and the modernization in oncology pharmaceutical services, which is the topic of the discussion in most of the oncology centers and within the pharmacy services. So the objectives we're gonna discuss is first of all, we will discuss about the expanding role of the oncology pharmacist and the oncology services. Then we're going to see what are the standardized, specialized oncology pharmaceutical services which we can offer to our patients. Then if you have to standardize or modernize, what kind of standards you will choose from the available resources. I'm going to discuss in detail about the Quality Oncology Practice Initiative, we'll call it QOPI from the ESCO, in detail about that one, and especially specific to the oncology pharmaceutical services. Then I'm going to discuss or will guide you about innovation and advancement in the oncology services related to the QOPI. This is a very broad, very complex topic, and I will try to muffle it and try to be to the point and specific during my presentation. So I need your 1 minute on this slide because I would like to summarize all my presentation or concept in this presentation. Oh, sorry, in this slide. In this slide, if you will see that, I'll just read for you for very quickly. As per organizational policy, you are dispensing intrathecal chemotherapy in a separate sealed box. Somehow you run out of the box. What would you do in that case? You will dispense intrathecal without special container or into same box with other chemotherapy as its urgent medication? Or would you delay to dispense until you will arrange intrathecal box at its concern with the patient safety? So in this scenario, there are 4 or 5 things are involved. I mean, what is the intrathecal policy? How did you arrange your policy? How did you establish your policies? What are your current practices? Their intrathecal policies is being reviewed by the 3 other. So if you want to take your practices onto the other level. So you guys will agree with me that in the last past decades or some a few years back, the oncology pharmaceutical services has developed its branches all over the oncology center. And we have to target 2 things. I mean, you have to understand in any process, if you didn't able to establish your value, you will be eliminated. So you have to establish your value as per your patient, as per your organization as well. So Fortunately, I think I will not talk about the other. I don't know about the other specialty of the pharmacy, but for the oncology pharmacy, yes, they have developed different branches. If you will just go for one of the segment like oncology clinical pharmacy services or aseptic IV compounding of chemotherapy infusions, they have numerous further branches in that one. So it's going to tell you that really that the if you will say that the oncology pharmaceutical services are the integral part of any oncology center. From here, if we have to standardize or advance ourselves, the first thing we have to see our personals. The person who is valued or who is giving you the services, are they specialized? And the question we need to ask about ourselves, that do we need a specialized oncology pharmacist, and why we need it, we're gonna discuss in that one later. So if you will go for the value of the pharmacist, oncology pharmacist, you have to understand there's a lot of data of medication errors. So we have to, I just took one of the example from the Pennsylvania safety report, and there you will see there is two kind of errors whenever you observe in any medication report. There are, I don't know, it's become a pattern like this, that there are prescribing errors and there is administrating errors. These are the two bigger source of the errors. So we as a pharmacist lie in between this one. So if you have to eliminate the prescribing errors or the administration errors, you have to perform your activities over here. And if you will see in an oncology settings, there are a lot of prescribing errors. So what are the reasons of this? Even with the whole advanced practices all over the world, there are a lot of medication errors going on, especially in the oncology. So that give us a room or opportunity to develop some system, to advance our system, or have to change our current practices so that we can eliminate those flaws in our practices. Yes, that is one of the reasons we do need the specialized oncology pharmacist. Moreover, if you will just see that slide from the last 10 years or decade, the oncology paradigm is totally has been shifted. There are almost 250 drug approvals in last 10 years only, and just 30 or plus in the last 2 months. And the more treatment options are coming, more complexities are coming. And complexities in not terms of, I mean, the treatment options, it's the combination of the treatment options, as well as the new mechanism of the medication, the new technology of the medications. So they are bringing the new type of errors and the new type of responsibility to the oncology pharmacist. I will just share some few examples of our current practices that has been we are doing, and we are facing a lot of issues, and we are developing a new policies and new procedures and new kind of practices setups to cope up this type of therapies. And I will just name few of them. One is the CAR T cell therapy, BiTEs therapy, anti-GT2 therapy, and some immunotherapies. Especially about the BiTEs therapy, we have a lot of issues. We have a lot of new, type of practice changes has been evolved during administration and handling, and as well as the side effect of this kind of treatment plans. So the concept is that yes, we do need a specialized oncology pharmacist, not only in the clinical side or specialized services on that one. Even for a pharmacist who's working in an oncology setting, he has or she has to specialize themselves, either by the training from the internally side or either from the external side. So with this conclusion, we reach to the some point that we have very expanded role of oncology pharmacists in medication therapy management of the patient, in the guidelines, development of the guidelines, policies, standards, and clinical pathways, or if we have to provide the patient care on the bedside, and even with the like educating other members of healthcare team, then stem cell transplantation, hematology, oncology, immuno-oncology, as well as the aseptic therapeutic and compounding. So as we discussed that, okay, fine, we need the specialized oncology pharmacist, how you will specialize yourself, how you will advance your skills, how you will, say that we have working in an oncology center or and providing the oncology pharmaceutical services, then how to specialize yourself. This is one of the slides taken from the HOPA, and this is the pathways you can use to say yourself that you're a specialized oncology pharmacist. Yes, we do need to have some patterns, some pathways involved in it. So if we will talk about the standardization, which is the second part of our discussion. So standards serve as the foundation of an evaluation process that can help organization to measure, access, and improve performances. So remember, what we are doing is all patient-centered. We all are working for the patients. Either we preventing the errors, either we involve in the innovation or creativity, either the strategic direction of the organization, or it is the integrity, complexity of the therapeutic treatments or the options. All we are doing for the patient. So if we have to advance ourselves, we have to concern about the patient safety first. So as far as the choosing of the standard, so we have different available standards worldwidely, either it is for Cancer Care Commission, either from the ASHP, either from the QOPI or the JCI. So we have to see about our resources, and we have to see the expansion of our scope, and then we will choose from one of the our available standards. Sorry, I was disconnected. I don't know what's is it okay now? Fine, I'll go with this. So we'll discuss about the QOPI certification program that has almost 140 standards on which they certified you about the oncology services, and what the benefits of the QOPIs are as a reputation as a champion of quality care, access to quality and safety, a foster culture of excellence and self-examination, intent to reduce the risk of errors when providing chemotherapy, and practice improvement. Our organization, National Guard Hospital, is being certified from the QOPI. And if you will talk about the QOPI gonna certified you on the three standards. They have policy, they have the process observation, and they have the patient documentation. And as I told you that the QOPI is very peculiar to the oncology services, and then oncology services for the clinical pharmacy services as well as the generalized oncology services. We'll discuss that one in the other slide. So I will just jump towards about the domain one. They have 4 domains, and there is domain 1 and domain 3 is only specified for the pharmacy department. So according to the domain 1, they are very clearly mentioned that the chemotherapy is prepared by a licensed pharmacist, pharmacy technician, physician, or registered nurse. And it's document comprehensive chemotherapy preparation education, initial training, and annual education for the competency validation. But the most important is the domain 3, where they are more concern about the chemotherapy infusions, how they've been ordered, what are the process, and what the quality improvement in that one. So if I will discuss about that is there are different, you can see the parameters where they validate your practices as when a chemotherapy infusion is septic services. The most important is, if you will see that this is the chemotherapy template they want for the pharmacy, and all the information in that they have to evaluate on that. So for the preparation wise, they have to identify, there is 2 patient identifiers: drug name, drug dose, route of administration, rate of administration, and the calculation for the dosages. They need the documentation evidence of these practices. Then for the verification to the standards, they have been observed that the documentation of the concentration, the volume, the diluent type, they need all these documentation in written or in system whenever you have to certificate them. And then the label demands from the QOPI is that these all informations are very importantly to be labeled on the final label of the chemotherapy infusion. And as I discussed earlier, yes, they do have some specialized policies for some different procedures or special preparations like intrathecal medication, intrathecal medication. So they have, I mean, few points they have to prepare separately in the different type of cabinets with separate preparation. They have to be located in isolated containers and delivered to the patient in a very safe manner. And there are other domains which they have to involve the pharmacist on it. That is, uh, we can say about is that about monitoring of and adherence of the chemotherapy after toxicity and its complications. So the clinical pharmacist plays a very important role in establishing and development of the policy and the standard according to that. So after I mean, as I discussed very sharp fastly, and I think it's been missed some points over there, that QOPI has advanced your practices as far as the pharmacy is concerned. They have a full chapter for the pharmacy, and they standardize you and your practices according to that. So one of the innovation you required as per the QOPI, as what we observed in that one is in the aseptic chemotherapy infusion. So there are a lot of technologies rightly we are using in oncology. Either it is from the advanced HIM system, there is advanced automated cabinet systems, there is TPN preparation for the oncology patients, as well as there are closed system transfer devices. So there are a lot of things are been introduced in the last few years in oncology. But one of the very important data, or one of the very important innovation is in about the chemotherapy infusion or aseptic compounding. If you will see in that data, if you are preparing from in the chemotherapy, there are different type of errors are observed there. I mean, if you will just quickly, if I will name about that one, it's about the wrong vehicle, wrong diluents, wrong deviation errors, while reconstitution errors, and there are a lot other there. And definitely there are datas are available, your internal datas will be there. Nobody can say that these are not happening. There are a lot of errors happening in that regard. That's why the QOPI has a very specified module according to these errors. So how to remove that errors and give the safe chemotherapy infusion to your patient is, we have innovation in that system is called medication workflow system. It's involved in therapeutic planning, in about your concomitant therapies, your volumetric preparations, in your gravimetric preparation, your documentation, and your lower cost. And it provides you the safety, the speed, the precision, flexibility, easy to use, integration, and the innovation as well. So if I will just give you a very quick summary of the gravimetric IV preparation, they have documentation and technology in each step of your process. You have starting from the receiving the order, that should have to be linked and integrated with your system, and then you have weigh it by the gravimetric method. Then there will be a barcoded system which gonna identify your medication or your patient exact dose, and whatever you will prepare, that will be weighed and gravimetrically approved. After your confirmation, the label will be generated, and then
Mr. Khurram, can you wrap up, please, within 1 or 2 minutes, please?
I think we are facing some distortion or technical issue on Mr. Khurram's side.
So, Mr. Khurram, can you hear us?
Mr. Khurram, your mic is not on. Please unmute your mic.
is that okay now?
Yes, okay.
So I will conclude my presentation on four notes: that we have an opportunity as an oncology pharmacist to expand our roles, and we have, if we are working on a very good, we have to go to an excellent level to advance and standardize our practices. We have to concern all our technologies, whatever we are introducing in our system, it should be related to the patient safety. Thank you very much.
Thank you so much, sir, for your valuable time and knowledge. Let us move on to the next presenter. Let me start by saying that the secret of crisis management is not good versus bad, It's preventing the bad from getting worse. So, having said that, let me invite my second speaker, Mr. Rehan Khan Niazi, Assistant Manager, Clinical Pharmacy, Shaukat Khanum, and he'll be speaking on the topic of inappropriate use of medication during COVID-19 pandemic. Please go ahead, sir.
Thank you, Zara, for your kind words. First of all, Assalamu alaikum, everyone. And I welcome you all who are here with the online session and hope that few hours that we have got along with us will help you to learn some practice related things. Today, I will talk about inappropriate use of medication during this COVID-19 pandemic. Well, before starting the presentation, this picture, the picture of the virus, this microorganism, this miniature, this has changed the dynamics, the socio-economic dynamics of the world. 2020 would be known as an era of, lockdowns, era of isolation, an era of mask, the era of sanitizer, an era where things changed, things totally took different turns. It exposed the flaws in our medical system, the perfect medical system that we are assuming that it is working the best possible way. But this virus exposed the flaws in our system, the flaws in our population, whether developed countries or developing countries. And in today's session, I will try to point some of those irrational uses, irrational practices that spread throughout the community. And well, at the same time, this virus promoted these kind of online session, online things, and ours is one of them. And I will try to make sure that during these 10 to 15 minutes that you have got with me, I provide you some of the practice related knowledge regarding irrational use of medication. Before starting my presentation, one question that I will ask myself and from you all: is there any treatment available for this COVID-19 virus? Is there any treatment for this COVID-19 disease, corona disease, whatever you call it? There have been rumors, whether it's on social media, print media, electronic media, or even many other government and non-government, associations, press, whatever you say. There are many treatments, whether allopathic or homeopathic or hikmat, what you say, they have been, on everywhere that this is the treatment that will work. This treatment will work. There have been many, observational studies, randomized control trials, and many other small trials, the studies that were published and showing that these are the treatment that will work. But now, with meta-analysis studies, what we have got, the results are showing that none of the treatment is working. And up till now, there is no such treatment available for coronavirus. I have shared one, example, the randomized study of the Solidarity trial that is showing that neither remdesivir, hydroxychloroquine, ritonavir, lopinavir, interferon, or whatever, none of them is working when it comes to the mortality and morbidity data in the hospitalized patients. And I'm quoting the Solidarity trial results. So this is showing that we haven't, there is no treatment. All we can say that we have breached the lines of the irrationality. First thing, what is rational use? I have quoted a definition of the rational use. Its patients receive medication appropriate to their clinical needs in doses that meet their own individual requirements for an adequate period of time at lowest cost to them and their community. I quoted this definition because the element of the cost. This is one we were missing in the previous definition of the rational use of the medication. Otherwise, it was right drug, right patient, right dose, right route, and right time. This is what we say is the rational use of the drug. But this is along with these things, the rational use. It's in the cost effective. It is in the right cost that patient can afford. What COVID does, we bypassed many of these things when it comes to rationality and the factors that led, who are the major contributor in this. One is, you can say, the prescribers, irrational prescribing. None of them followed the proper path. Many bypassed those guidelines that were available, and they gone through even the practitioner followed those that material that was available on the social media, and these biased information. They followed those biased information for the treatment of the patient, and they bypassed many things that led to the irrational prescription and irrational treatment and this thing. But again, all I can say that we need to look for control of this thing. of prescription trends. Other thing was the role of the pharmacists and the pharmacies or the distribution setups. What they did, they sold things that were cheaper at very higher cost. Many times there were, cosmetic measures being done to show that this drug is short in the market, and it was sold in the black market at very, very high cost. Taking it out of the reach of the many of the patients who were actually taking these medication for different other indications. And third important is the irrational use of medication by the patients. Patients at the same time were following social media, many other these misleading information there in the print media, and they started to blindly follow rather than looking rationally or think following the guidelines being provided by the medical professionals. They bypass those things and they start to take those medications as self-medication, thinking that these are the panacea, these are the things that will treat them, not even thinking that it may have some harm impacts upon their health, their nears and dears. Well, it all started with the hydroxychloroquine and chloroquine thinking in the past study. I think 2013, there was a few studies showing that these may work against the coronavirus, the SARS-CoV-1, and world start to blindly follow that the hydroxychloroquine is the one that will save the lives of our nears and dears. And whole the world started to look for hydroxychloroquine, and there was sudden drop in the market, and it wasn't available on any of the pharmacy. Even those pharmacies who were having it, they were selling it 10 times the higher cost. Each tablet was sold around 200. I'm telling you the minimum 100 to 200 per tablet, even though it was costing in normal days around 10 to 20 rupee per tablet, but it was sold at very high cost. People started to take it on routine basis. It led to the metallic taste, and those with many other cardiac issues, it led to the QOPI prolongation at torsade points. But people took it. People start to follow blindly. Even the medical professional, they start to follow it blindly without thinking rationally what may be the impact about the dose and these things. And another thing is this, the drug interactions. One thing, the president, Mr. President, past president of America, he said that azithromycin and chloroquine, hydroxychloroquine, they work very nice for the treatment in corona. And FDA at the same time had to, second his words, and world population start to follow this practice, hydroxychloroquine, azithromycin, without even thinking that they may have interaction. Many who knew about the interaction, they even bypass this thing, and rather than treatment, it led to the QT prolongation, many other GI and other side effects that led to the death, may not because of the COVID, but because of this combo. So we saw that azithromycin, that is actually antimicrobial. And in third world countries, especially in Pakistan, where it is among the first line medication to treat the Salmonella typhi, the XDR Salmonella typhi, it wasn't available in the market. Suddenly azithromycin was short in the market, thinking that it is the one that will treat the COVID. I'm sharing you the data of 2019, the typhoid. Here you see the months of June, July, August, September. These were the months where there were peak in the typhoid in Pakistan. And you see the COVID peaks, they were also during the same days when the days of the peaks of the typhoid. And what happened, the many patients who were suffering with the typhoid, they were unable to find the azithromycin, because in XDR typhoid, these third generation cephalosporins, these doesn't work. Quinolone doesn't work. All you have in your hand is azithromycin or carbapenem, and carbapenems are very costly. Azithromycin is safe and oral option available for treatment of this XDR, but those patients were being deprived from this life-saving medication for them, the actually life-saving medication. That actually it was a life-saving medication for XDR typhoid patient, but those who were not needing, they were supplied with this medication. Other thing is tocilizumab. It was thought that it is the one that will be life-saving drugs, and those patients who were not even necessary for hospitalization, those who weren't with the respiratory symptoms, physicians prescribed them and they got administered, and people were buying in they were paying millions. It was sold through back market in millions, and people paid millions thinking that it will save the lives of their near and dears. But unfortunately, it happened. It did work, but recent study I'm sharing in NEJM, it is showing that there was no such morbidity and mortality benefit with tocilizumab. I have some reservation because we observed some benefits for the patient, but again, it wasn't that much beneficial as it was promoted, and the shortage that was caused, and the people, how much again, the cost element, how much costly it was. At the end, DRAP has to come forward to with the guidelines, but it was too little and too late. By that time, many people had spent millions for saving life and their near and dears without even thinking that it is whether it is life saving or not. But for them, it was life saving, and many physicians started to say that it is life saving. So irrational. Self-medication is one another challenge. There was too much self-medication, people taking hydroxychloroquine, azithromycin, and this thing inappropriate, leading to too much consumption of antibiotics, especially azithromycin consumption. If God forbidden XDR typhoid, it get resistant to azithromycin, we are short of the options. And even if studies, I was saying there was that self-medication facilitate better healthcare and reduce prescribing cost. How can it reduce the prescribing cost? Yeah, at the same time, self-medication is very harmful. We should never encourage this thing by any means. There is no benefit of this thing. We shouldn't say that it is beneficial. Self-medication is, you are poisoning yourself without knowing. And the irrational dilemma of antibiotics, people with the respiratory symptoms, they were being started on carbapenems, on vancomycin, and many other without thinking the hazards of the resistance. And what happened? It led to the consumption, and it led to the resistance. Development of the resistant strains. I'm sharing you the antibiogram of our hospital. You can see from in first quarter, E. coli data. E. coli is your gram-negative bug that is there in the gut. You can see the sensitivity dropped from 88% to 74% in a matter of 3 quarters of 2020. There's a huge drop. What it has done, it has led to the consumption of colistin and these life-saving medication. Colistin is, the last tire for the MDR bugs, and there is rise in the colistin, consumption. And if God forbid, if the resistance to colistin, what we have got in our hands, we are in developing countries. We don't have all the options we have. We don't have the new generation antibiotics, just like meropenem, vaborbactam, or these things. So we should be extra careful in managing these things, but unfortunately we missed these things. For example, irrational use of antibiotics during COVID-19. What it has done, it increased resistance. What it has done, increased use of second and third line antibiotics. For example, if it's resistant to cephalosporins or piperacillin tazobactam or carbapenem, then you are stepping from one line to the second line or third line. It has, and when you cross to the next line, it increases the cost of the therapy. And we are running out of the treatment options. We are in developing country. We are not having all those fancy drugs, the new generation antibiotics. We are not having them. We wouldn't be able to provide our patients. It will lead to more deaths than the COVID. So the way forward is, first thing, we should never encourage self-medication. We should discourage self-medication. Other thing is that DRAP and other government healthcare authorities should be proactive and set guidelines and standard to avoid misuse and black marketing of the medication. There should be checks on the prescription right and privileges of the physician. Not every physician should prescribe every antibiotic or RE medication. For example, the carbapenems, not every practitioner should prescribe. There should be some specialization for those who have got the privilege to prescribe these or approve these. For example, the ID physicians or ID fellows, or those who are the consultant, the pulmonology consultant or IM consultant, they should have privilege to prescribe these medications, not every medication, not the resident, not the GPs. So there should be some rights when it comes to prescribing of these antibiotics. And last and the most important part, the role of the pharmacist, whether in the community, hospital, or even the clinical pharmacist, they should ensure their check on irrational use through vigilant review of every prescription. Whether you are reviewing prescription in the hospital or in the community or anywhere, you must show that it is rational, it is meeting the needs of the patient. You must educate the pharmacist, physician, nurses, patients, and their attendants regarding the appropriate use of the medication. You can even guide them related to the use of different medications, so that to ensure that every medication is used safely, especially those who are in third, developing countries. We have more onus over our shoulders, knowing that our community is not much rich. most of our fellow people are poor and they can't afford many of the medications. So we need to reduce this cost burden. It will add to the rationality and improve the therapeutic outcome for our population. With this, I will end my presentation with the hope that 2021 will usher the way of ending this COVID, and hope the vaccination or other treatment, whatever options available, will work to control this menace, this pandemic, inshallah. Thank you very much.
Thank you so much, sir, for that highly thought-provoking presentation. And guidance like these is much needed and highly valuable during these confusing times. So let me introduce our third speaker, Mr. Salman Nasir. He's the Assistant Manager Pharmacy at Shaukat Khanum, Lahore, and his topic of presentation will be sterile compounding consideration during COVID-19. So welcome, sir. We are facing a little bit of technical issue, but Mr. Salman will be joining us shortly. Mr. Salman, kindly unmute your mic.
My name is Salman Nasir, and I'm working as Assistant Manager Pharmacy, and I would be talking about sterile compounding considerations during COVID-19 and essentiality of sterile compounding services in a healthcare setting. I have no conflict of interest, any kind of. These are uncharted waters, and working together, we can be successful. Sterile compounding services. In the first half of my presentation, I will be talking about the essentiality of the sterile compounding services and lesson learned from the past tragedies. And in the second half, I will be talking about the different strategies we've been guided by the governing bodies like USP, OSHA, FDA. So, sterile compounding, the process of compounding sterile preparation in the hospital pharmacies encompasses the preparation of the medication that are not commercially available based on the medical need of the individual patients. Compounding sterile preparations are commonly used for adults and children admitted to the hospital, home healthcare services for a range of indications. Therefore, it is essential that they must be prepared, labeled, and administered with an appropriate care so that the highest standard of safety, efficacy can be ensured and serious adverse reactions can be avoided. Compounding pharmacists provide patients with a personalized medication based on their preferences and restrictions. Although compounding error in sterile preparations can cause fatal injuries to the patients and may lead to the tragic deaths. A number of studies have been demonstrated that the incidence of serious compounding errors that frequently occur in hospital pharmacies were largely due to the improper medication and dose concentrations, infectious contamination, incorrect product labeling. A real risk of sterile compounding. Poor quality sterile compounding can result in a patient harm through problems with potency, sterility, presence of contaminants and particulates. In this regard, STEES International conducted a review of infectious outbreak from 2002 to 2012 resulting from the sterile compounding. There was 11 separate outbreaks, 207 patients impacted, and 17 deaths occurred. Most tragic of them was the New England Compounding Center fungal meningitis outbreak. It impacted 753 patients, 64 deaths. NECC resulted in a legislative action to regulate the compounding and establishment of a DQSA in 2013. By understanding each outbreak, we can hope to prevent the future event. So the governing bodies, through this pandemic, we've been guided continuously by all these governing bodies like USP, Joint Commission, FDA, CDC, ASHP, NICE, DQSA. So we were lucky enough to have guidance, direct guidance from these governing bodies. Operation considerations for sterile compounding during the COVID-19 pandemic. In light of the rapidly evolving COVID-19 pandemic, the demand on the compounding operations is expected to continue to increase and impose the challenges on the compounding entities. During this pandemic, USP support state boards and other regulators using risk-based enforcement discretion related to the implementation of USP compounding standards. USP Compounding Expert Committee has developed the operational strategies based on the stakeholder inputs and in anticipation of the challenges that may arise during the COVID-19 pandemic. The following operation considerations may supplement but should not replace the facilities, policies, and procedures. First of all, assignment of beyond use dating. This is most important of all. Consideration of certification and recertification of the equipment we are using and the area we are using. Cleaning and disinfecting the area and the equipment we are using. Sterile 70% IPA, isopropyl alcohol or SEPA, with which we are going to make our area or equipment sterile. Anticipatory compounding according to the patient influx and outflux, other factors and other strategies we'll discuss later. So establishment beyond use date. There are two main factors on which the assignment of BUD relies. Stability factor, chemical and physical properties of the compound, compatibility of the container closure system with the product they are containing. Sterility factor, environment in which the CSP is being prepared, like if it is prepared in clean room suite or segregated compounding area, does directly affect the BUD, assignment of BUD. Aseptic preparation and sterilization methods, whether we have used it or not. Components, sterile component or non-sterile component, we are starting with. Sterility testing, whether we performed it or not. Storage conditions, whether we've going to store the CSP on a room temperature or a refrigerator or in a freeze form. So there are some categories on the microbial contamination basis: high risk, medium risk, low risk, and low risk within 12 hours. But again, they are being divided into two categories depending on the environment they are being prepared in. Like category 1 CSP, they are being prepared in segregated compounding area with less than 12 hours BUD at room temperature and 24 hours at refrigerator. Likewise, category 2 are the CSP which are being prepared in a clean room suite, and they've been assigned a BUD of more than 12 hours at room temperature and more than 24 hours if they are refrigerated. Same here, category 1 CSP BUD, if they are being stored at room temperature, the BUD is less than 12 hours. And if they are being stored at refrigerator, it is less than 24 hours. Currently, official standard 797 describes 12 hours if it is prepared in segregated compounding area. Again, category 2 CSP BUD, starting with the non-sterile compounding, non-sterile components. Non-sterile components, we are going to make a CSP and sterility testing performed. We haven't done any sterility testing. So if we are going to store it at room temperature, it is 1 day. If we are going to store it at a refrigerator, it is 4 days. And if we are going to store it in a freezed form, it is 45 days. Currently, official standard states if we are going to store it at room temperature, it is 1 day. If we are going to store it at refrigerator, it is 3 days. And at freeze temperature, it is 45 days. Similarly, category 2 compounding, but we are starting with sterile components and we haven't performed any sterility testing. At room temperature, it is 4 days. At refrigerator, it is 10 days. And at freezer, it is 45 days. Same is the case currently. Official USP 797 states 30 hours for medium risk, 48 hours for low risk CSPs. If we are going to store these on room temperature, and 9 days for medium risk level at refrigerator, and 14 days for low risk compounding. If we are going to freeze it, it is 45 days in both of the case. It is the summary of the previous 2-3 slides. I'm going to rush towards the next slide. So the crux of the previous couple of slides is that if we have done some sterilization methods, some sterility assurance, or some storage condition, we have assigned some. So we can assign a BUD on the basis of these 3 factors. If we have performed some sterilization method, we can assign a longer BUD. But if we haven't any, we'll have to assign minimum possible beyond use date to the CSP. Likewise, sterility assurance and storage conditions. Consider, considerations for certification and recertification. The second one is consideration for certification and recertification. Primary and secondary engineering controls should not be used without initial startup certification. Understanding resource constraint during the COVID-19 pandemic, facilities may consider delaying recertification of primary and secondary engineering controls. They are served by continuous monitor. We can delay, but if they are being served with a continuous monitor, manual or some digital one. The continuous monitor may help assure that a state of control is established and maintained from the previous certification. The interval between the certification should not exceed 12 months. Consider increased environmental monitoring and applying shorter beyond use date if certification is delayed. Cleaning and disinfecting. In addition to the cleaning and disinfection standard 797 to help ensure the quality, CSP, the Center of Disease Control, CDC, has published consideration for cleaning and disinfection of the facility. Following facility policies and procedure for environmental cleaning and disinfection consistently and correctly. Routinely clean and disinfect frequently touched surfaces and objects. Use soap, water, or EPA-approved detergents. Follow manufacturer recommendations on contact times. Consider EPA-registered disinfectants and their reactivity with the surface material we are going to apply on. Dispose of clinical supplies accordingly, according to the facility SOPs. Sterile 70% IPA. USP 797 describes sterile 70% IPA should be used for cleaning purposes. But if we are running short of it, we should be conserve SEPA for injection ports, vials, septa, ampule, necks, and the equipment we are going to prepare in the CSPs. But if we are not provided with the SEPA, like it is short in the market, we can use commercially available isopropyl alcohol, and we can make it sterile by filtering it through a 0.2 micron filter, and then storing it in a sterile container. If we are not available with a sterile container, we can make them container sterile, and then we can store the but we have done sterile isopropyl alcohol in that container, and once it is open, it should be closed. It should be contained in a classified area. Anticipatory compounding. In hospital practices, anticipatory compounding is the process of making limited quantities of the compounding medication that are not patient-specific, but in preparation of a certain number of expected patients and will be used in the near future. Anticipatory compounding is based on historical demand, reduces the wait time for patients and providers. Arguably, arguably the most important work in emergency response is the work done in the preparation. So depending upon this code, we can escalate our work. Other factors or strategies are knowledge sharing. We've seen a massive sharing of knowledge over the internet and among the healthcare providers. Redesigning the pharmacy workflow that is specifically based on the workflow, workload, and facility-based stock management. We've increased our stacking capacity. We've increased our inventory levels, expecting shortages of the markets, of the PPE, of the medicines. Communication. We've communicated a lot between different facilities, different like NIOSH, OSHA, FDA, USP. So there's a lot of communication going on, and it is being shared with all the healthcare professionals. Safety and public responsibility is also with the help, without the help of which we can't be successful. So there's a 4S of surge in the time of preparedness. Being a hospital pharmacist, staffing, space, supplies, and systems. So we need all of them on board to deal with such a situation. So concluding, storms make trees take deeper roots. So stay positive and stay safe. Thank you from my side.
Thank you so much, Saman. That was an excellent presentation. Now, I see some questions coming in, but I would like to remind the participant that the question and answer session will be held at the end of the session. So save your questions for that later. So let me invite our final speaker for the session, Mr. Ghulam Mushtaba. He's the System Manager, Clinical Pharmacy at Shaukat Khanum, and he'll be talking on the topic of pharmacist role in the treatment of SARS-CoV-2 pneumonia in critically ill patients. Presenter and ask them directly.
So, I have just shared my screen.
Yes, sir, we can see your screen.
Okay, thank you so
Okay.
much. So first of all, I would like to thank our symposium committee who has worked tirelessly to make this event successful. And I would like to thank my pharmacy management for this amazing opportunity where I'm able to present an amazing work of our fellow clinical pharmacists during this recent pandemic. So, learning objectives of today's talk, we'll discuss little bit about the SARS-CoV-2 pneumonia, then treatment updates based on the disease severity. Then we will discuss different roles of clinical pharmacist. I have bifurcated these roles into the administrative roles and clinical roles, which are the direct patient care activities, and at the last of the presentations are references for review. So in case if we don't remember, the first case of the novel coronavirus was reported in Wuhan, China in December 2019. So on 11th March 2020, WHO declared the outbreak a pandemic. And in Pakistan, the first 2 confirmed cases were on 26th of the Feb. So in last 9 months, since the virus has infected more than 33 million people and killed more than 1 million. So case fatality ratio varies from 9.9% to 1.1% in different parts of the world. And this case fatality ratio also varies in different age groups, like the elderly and the patients with the comorbidities. They have higher mortality with SARS-CoV-2 pneumonia. So in Pakistan, case fatality rate is 2% of the total cases. Treatment updates. These treatment updates have been taken from the latest NIH guidelines, and these guidelines have been based on the disease severity. Like the patients who were RT positive, either they required hospitalization, and with the hospitalization, either they required supplemental oxygen like non-invasive ventilation or invasive ventilation, and the mode of ventilation. So these recommendations are based on the 2 landmark trial. One is adaptive COVID-19 treatment trial, ACTT, which was a randomized international trial which compared remdesivir with a placebo. And another is recovery trial. We all know from the mainstream media, the recovery trial, there was so much hype in the media that the dexamethasone actually resulted in mortality, in reduced mortality as compared to the control arm. But remember that mortality was in the patients who required supplemental oxygen. So why am I telling this? Because after 9 to 10 months of this pandemic, since the start of this pandemic, now we have established treatment regimens. We have established treatment protocols. But in the early, it was all hit and trial methods. Studies were not enough, and every treatment option, it was a chaos. And at that time, a role of clinical pharmacist was very important and crucial. In the upcoming slides, the roles that we will talk about are these. First and foremost, inventory updates. It was to make sure that there were enough drugs available for the upcoming surge of the patients. So a systemic review and a meta-analysis of 37 articles with 25,000 patients, a SARS-CoV-2 positive patient, showed that the rate of ICU admission was 32%. And out of these 32%, 42% of these patients, they develop ARDS. So what does it mean? It means that these patients will require moderate to severe sedation during the course of ICU stay and plus minus paralysis. It means there was going to be a surge and expected shortage of these critical items. So what we did in our hospital, we adopted some effective strategies. So we had a central control of inventory, and we, in the very beginning, we put some prescribing restrictions on the very critical items. Those items, either they were already short in the market or they were expected to be short in the market in the near future, like chloroquine, hydroxychloroquine, and azithromycin. In the ICU, we used validated sedation score to tailor the dosage requirements, and we made sure that each patient had the required level of sedation, and we don't waste our essential sedative medications. So one thing important during this pandemic, it was nalbuphine. Nalbuphine, which is a mixed opioid agonist and antagonist. It has sedative properties, which is a side effect of the medication. And we used that side effect to our benefit. We used it as an analgesic and sedative so that we can minimize the use of morphine for this particular indication, and morphine can be used for our palliative care patients. So shortage of these medications was expected, but there was some unexpected surge of some medications like insulin, glargine, and other insulins. So why did that happen? Because most of these patients, they were started on steroids, and some of these patients had diabetes as a comorbid conditions at the very start of their presentation. So these patients had dysregulated glucose levels, so they required high doses or even continuous infusions of insulin, so which created a huge surge in the demand of insulin. So as a ICU pharmacist and a clinical pharmacist, our pharmacists regularly updated our inventory team about this surge so that they can arrange a backup stock of insulin. So we also continued follow-up on our inventory of critical items, and we provided regular feedback to our inventory people. Uh, this was an era where newer drugs were introduced into the setups. So in our setup, we had tocilizumab, and our ICU nursing staff and the staff even on the pharmacy side, they were not used to it. And this was quite a new drug into our setup. So what we did in order to reduce the adverse drug reactions associated with the wrong administration, we formulated tocilizumab administration protocols. And not only for IV, but later on, when there was a shortage of IV tocilizumab, we changed the subcut to IV. And with all these, we provided regular updates to our nursing staff as well as pharmacy staff. We also formulated administration protocols on cisatracinium as vasopressin, and these were regularly taught to the nursing staff as well. So monitoring of adverse drug reactions is an important task of our clinical pharmacist. It was during this pandemic, the causal assessment of the adverse drug reactions was quite a challenge, because it was kind of a bizarre situation. We could not differentiate between a normal disease pathology and drug associated adverse drug reactions. So, with tocilizumab, patients in which we use tocilizumab had acute derangement in ALT, AST. But again, a study showed that COVID-19 positive patients, they had elevated liver enzyme, which was a normal disease process. So we documented all these adverse drug reactions for the future safety measures. Bradycardia, it was seen in the patients who were deeply sedated, especially with dexmedetomidine and propofol infusions. And then prolonged QT. We later will discuss about this aspect of this important interaction of hydroxychloroquine and azithromycin. As you can see here, this patient was started on enoxaparin. Platelets were low. Enoxaparin was dose was adjusted, but then again, patient had an oral bleed even on the adjusted doses. So ADR was reported and the enoxaparin was held. And this care plan is formulated by a clinical pharmacist. Drug interactions. As I was previously telling you that all those patients who were started on hydroxychloroquine or chloroquine in combination with azithromycin, they had a greater chances to develop QT prolongation. So in our initial 26 patient, 4 out of 26 developed prolonged QT. So later in the days, what we did, we formulated a plan where all the patients who were started on this combination, they had a baseline ECG, and if the QT was prolonged on the baseline, all those patients, they did not have this combination. Or even during the treatment, ECG was done shift-wise, and if the QT was more than 450 milliseconds, either the drugs were changed or the treatment was interrupted. As we know that viral infection, they precede super added bacterial infections. Although that is true, but during this COVID-19 days, many patients, they got unneeded just in case antibiotics. So even the WHO issued a warning on this important issue. So according to studies during these pandemics, they show that 60 to 70% of the COVID-19 patient had received empiric antibiotics. So depending on the country and the healthcare setting, maximum of 20% of the patients, they had actually true secondary bacterial or fungal infections. So it means that almost 30 to 50% of the time, antibiotics were used inappropriately. So a second meta-analysis, it was done that showed bacterial infections, they ranged from 5.9 in the hospitalized patient to 8.1 in the critically ill patients. And the actual number of patients who received antibiotics, actually broad spectrum antibiotics, it was 71%. It means almost 60% patients, they received broad spectrum antibiotic without any culture results. So this increases the selection pressure on the antimicrobial resistance. And this was a very common issue, and we faced this issue as well. So in Shaukat Khanum, we have a very established antibiotic stewardship program. So in addition to that, as the in-person rounds during this COVID-19 pandemic were not possible for every specialty, so we had some specialties as part of COVID multidisciplinary teams. ID physicians were part of this team, and these antibiotics were regularly discussed with the ID team. For example, in that particular case, vancomycin was started depending on the blood cultures, which grew GPC in cluster, but later it showed a staph epidermidis, which is a normal skin contaminant. It was discussed during the MDT and the drug was discontinued. Early in the pandemic, there was not enough literature available, and stewardship of SARS-CoV-2 treatment options was necessary. Actually, the only option that we had at that time. So our pharmacists, they did a daily review of the literature and discussed it with the ISO physicians. And based on that literature, we formulated some dosing protocols for some drugs. For instance, we were using escalated doses of enoxaparin in our patients for prophylaxis. Nursing educations, as you know, these critically ill patients, they were on multiple infusions, which makes very complex to administer simultaneously via the Y sites. So we regularly provided teaching to the staff on the Y site compatibility of the drugs. We provided them chart, and moreover, we also taught them on the stability and reconstitutions, because during these days it was the physical interaction and uh, the the regular interaction was not possible due to some precautions. And also the nursing staff were very busy. The shifts were quite busy, and it was not possible each time that they had some new drug that they would call the pharmacy and ask what is the Y site compatibility, either I can use these drugs through the Y site. So we provided them education material proactively. uh, in order to cut the cost and reduce the wastage of an essential medicine, at that time it was considered essential, tocilizumab. We were rounding off doses. Like if the calculated dose was 460 and the vial was 400 strength, we were rounding off the dose to nearest possible of 400. Similarly, all those patients who were orally free and they were tolerating oral diets, their medications were changed from intravenous to per oral. We also made sure that uh, we were following albumin use restriction, and we minimized its use as a colloid. Uh, Also, we had some treatment alternatives, some cheaper treatment alternatives, and not only we tailored use of morphine for our palliative care patients, but it was quite uh, a low cost drug. As you can see here, from 1st March to 31st July, our clinical pharmacists performed around 6,000 interventions. And out of these 6,000, around 270 interventions were placed on the orders where IV drug was changed to per oral. And you can see here that almost 90% of these interventions were accepted by the physicians. Uh, Dose adjustment was also quite a challenge, as the data tells. A retrospective study of around 5,000 patients admitted with COVID show that AKI developed in 36% of the patients, and stage 1 AKI was most common. And actually, 15% of these patients, they require renal replacement therapy. So the pharmacokinetic monitoring and dose adjustment becomes more essential in such patients. So our clinical pharmacists performed clinical interventions if dose adjustment was necessary and they required monitoring. So as you can see here, in the same time period, there were 2,700 interventions were placed for inappropriate dose, where the dose either was not accurate or there was a requirement of dose adjustment in view of the acute renal failure or acute liver failure. So total interventions were 2,700, and again, the acceptance rate was more than 90%. As you can see here in these two plans, in the first plan, the patients had a creatinine clearance of 36, and the pharmacist has put a note to avoid nephrotoxins. Similarly, in the second case, a patient was on subtherapeutic doses of cisatracurium, which is a potent paralytic, and it was discussed with the physician and the team, and the doses were increased from the 10 milligram per hour to 20 milligram per hour for the next 24 hours. Uh, as I already told you, that the in-person round and the in-person consultation and the physical examination of these patient was not possible due to the COVID precautions, and also to reduce the wastage of essential PPEs. So we started these MDT meetings where ICU consultant, ICU senior instructors, ID physicians, nephrologists, pharmacists, they discussed the patient care plan, and some pharmacotherapy-based decisions were made during these meetings. Now we know that the only way forward for this pandemic is an ongoing research. So in Shaukat, Khanum, our hospital leads the way in the region. So we have two ongoing trials. One is Solidarity trial, which is an international randomized trial of additional treatment for COVID-19. And another is a phase 3 clinical trial to evaluate the efficacy, safety, and immunogenicity of the recombinant novel coronavirus vaccine. Our pharmacists are part of these trial teams, and starting from the IMP receiving till their storage, their monitoring, dispensing, and monitoring and reporting of adverse drug events, it is done by our clinical pharmacist, our dedicated trial pharmacist. So what is the bottom line? So pharmacist role has changed from making medicines to make the medicines work. Be proactive, adaptive, and team player. Think out of the box. You will have some alternatives. Document your interventions and study the impact on healthcare costs. Stay focused, stay up to date with evidence-based guidelines, and speak up. Uh, Thank you so much. I think question and answer session is at the end of the session.
Thank you so much, Sir Mushtaba. That was really a valuable presentation in terms of highlighting the vital role a pharmacist, a clinical pharmacist can have the potential to play in a hospital setting especially. So next will be our question and answer session. It will be of 10 minutes. So I will remind the participants and also our presenters to keep their answers and their questions very short and to the point. So can we have all the presenters live? Okay, so I have a question for Mr. Rehan, first of all, from a participant. Let me start. Excellent presentation, Mr. Rehan. The question is that what measures were taken by our organization to deal with the drug shortage of drugs reported in COVID-19 trials, like dexamethasone, azithromycin, etc.?
Thank you. A simple answer is this: you have to be proactive. In our institution, the clinical pharmacist, the inventory team, the ID team, we were all on the same page and we were proactive. We knew the disease course of this COVID virus, as we GM told that Ghulam Ashwa told about the admissions, how the disease pathway, the pneumonia that the patient develops, the ICU needs. So they were all needing these medications. We arranged that stock before the other people were reacting. We were proactive before the reaction of the people, and we thought clinically, and we arranged those medications that were going to be the need of the patients who were being admitted for this COVID disease. So we had enough stock of all those medications. We sat together, we thought proactively, we arranged all those medications, and we had an expected number of the patients that we want to have during this pandemic, and we had that stock above that expected number of the patients, so that we can meet those needs in the time of this COVID pandemic. And alhamdulillah, we were there. We had all the stocks and all the medicine available, and we were able to treat all patients with all those necessary medications because of being proactive, following the course of therapy, following the research that was there, that the treatment pathways that was unearthed, and also knowing our clinical skills based on the pharmacology and the disease etiology of this COVID disease.
Thank you so much, sir. So next question we have for Mr. Salman, whose topic was centered around sterile services. Mr. Muhammad Aslam asks that while deciding the BUD for any sterile preparation, what we consider most while deciding, as per USP 797 BUDs or chemical stability as per manufacturer's recommendation?
Thank you. It's a very important question, and I would like to answer it. We will consider both of them. I mean, we'll have to consider the stability concerns of the the product we are going to make, and as well as the sanitary condition or the guidelines to compound that particular medicine. For example, melphalan is an antineoplastic agent, and it is only stable for 1 hour. So we have prepared it in an ISO class 5 environment, and we have met all the steps we use to make our sterile product, but it is not stable more than that, more than 1 hour. So we can't do anything. So we'll have to consider this one. On the other side, once product is stable for, let's say, 2-3 hours, 7 days, or 7 days, for example, but we haven't considered anything. We've prepared this medication in a very insanitary conditions, so it's not going to make it. The ultimate goal is patient outcome, the clinical outcome we are going to get through these. If we've prepared some non-sterile product containing a lot of things, endotoxin or cultures or particulate matter, so it's not going to help the patient. So we'll have to consider both of them, stability concerns also and sterility considerations also. Thank you. I hope that answers the question.
Nice, very nicely answered. So the next question is for Mr. Khanum. Sir, what is the future of pharmacy you see in Pakistan?
Well, it's very bright. It's very expanded. So I've been away from Pakistan from last 10 years or so, but it's evolving. It's creating its branches. Well, for oncology pharmacy, yes, there is an institutions over there like Shaukat, like Aga Khan, like there are others, and mashallah, the people, the graduates, they are evolving in that area. Yes, I feel very promising, and it looks very bright future over there.
We hope so, really, truly. So next question is for Mr. Ghulam Mushtaba. What role can a pharmacist play in establishing evidence-based treatment guidelines of COVID-19 in Pakistan owing to the limited resources we have here?
Yes, thank you so much. That's an excellent question. And I would say that literature review is the answer. So first of all, if you are not part of any team, you should be a part of team or any multidisciplinary teams, and then you should have enough literature review on your hands so that you know what is going on, what is the latest research, and what does the evidence tell. That is how you are going to have abundant resource.
Okay, thank you so much. So that was the conclusion of our question and answer session. Thank you so much for your questions, and thank you so much, presenters, for answering them in such a timely and an informative manner. Now, let me invite our chair, Dr. Muhammad Tahir Aziz, to share some valuable thoughts and motivational words with us and conclude the session.
Okay, I think you can hear me.
Yes, sir, we can hear you.
Yeah, thank you very much. I would like to thank you all participants. Mainly, the main presentation is a very informative session, an excellent presentation by all speakers. I would like to congratulate to all Khanum, Mr. Rehan, Salman, and Ghulam Mushtaba for their excellent presentation. And they have, defining a very good, questions of all, participants. So in the end, I would like to thank you once again to all, the speakers as well as who hold and arrange all these sessions, my pharmacy staff, excellent presentations and done. And I would like to thanks to all, attendees who have attended the session. And good luck to all of you. Inshallah, we will continue such exercise in future ahead. Thank you very much.
Thank you so much, sir. So what a wonderful opportunity this was to connect with all of you. And as they say that behind every successful event, there is a team of ambitious and hardworking people. So I would like to thank our team of moderators, Dr. Tahir Aziz Mughal, Dr. Mr. Umar Ikhlaq Bhutta, our speaker, Mr. Khurram Shehzad, Mr. Salman Nasir, Mr. Ghulam Mushtaba, Mr. Rehan Khalniazi, and all the Shaukat Khanum Symposium team whose efforts made this event such a success. So I would like to close the session by saying that prosperity is a great teacher, but adversity is greater. Thank you so much.